Okay, well, let's get started. Hello, everybody. Thank you so much for joining this event where we're here to have the first of a series of COVID Q&As. So I'm your friendly host. I'm Gareth Mitchell in my living room here in South London. I'm with Imperial College. I'm one of the Science Communication MSc lecturers, but also outside Imperial College, I live in a parallel universe. So I also work at the BBC as one of the BBC Radio Science presenters. But enough about me. I'm just here to ask the questions, to get the conversation going, and also to hear from you, dear audience, joining us on the stream about your thoughts and your comments and your questions. So we are going to have this series of COVID chats over the next few weeks and indeed months. This is the first one. We'll get cracking on that in a minute. Just as you might do with a physical event pre-lockdown, of course, there is some housekeeping. In this case, I'm not going to be pointing you to the nearest fire extinguishers or to the nearest fire exits. But what I am going to tell you, first of all, is that this event is being recorded because we want people to be able to enjoy it in the weeks and months to come. So if you do pose any questions, it will be in the chat, and of course that will be part of the recording. Which brings me to the next thing. So we'll be getting your questions via the chat. So even as you sit there now or stand or whatever you're doing, then do add your questions to the chat, and our moderators will go through them and we'll make sure that the very best questions get to our speakers. And speaking of the moderators, this session is being moderated, and that's mainly because we just think things will go more smoothly. We can sift through the questions and just make sure that we're able to have a good sort of curated conversation with our guests, just to keep things ticking along really nicely. So in your questioning, by all means, give us your name, but if you'd prefer to, you can stay anonymous. And of course, we would ask you not to share any personal information on the chat. And also, if you're reading through the question list and there's one that you particularly like, then you can upvote it. So to the power of the crowd, we can make sure that the really popular questions get through as well. So do remember, you can upvote those questions. If you're struggling to connect to the Teams, it can be a little bit bandwidth hungry, then we're also streaming live via YouTube. So you can go onto there. The best way to find it is go to youtube.com and then / Imperial College Video. So that's all the housekeeping set up. But I think we should get straight on and meet our speakers. We have three amazing Imperial researchers here to give you the latest on what's going on in their research and in the response to coronavirus. And we're going to start with Dr. Juliet Unwin, and she's with the School of Public Health and the Faculty of Medicine. In fact, all three of them are from the School of Public Health today. And Juliet, I wonder if you can just introduce yourself, tell us just briefly what you research, and if there's anything especially surprising about what you do that's going to get our audience out there on a hot afternoon to go, woo, like that. So tell us a bit about yourself.
Hey, thanks, Gareth. So my background's a little bit different to quite a lot of people in infectious disease modelling. I have an undergraduate in mechanical engineering, and my PhD too was in engineering, and I looked at how you can model things when there's lots of uncertainty. It's really surprising, but actually there's lots of similarities between how you model engineering systems and also how you model infectious diseases. So a couple of years ago, I took the jump and moved to the School of Public Health and looked at modelling malaria and how you can use malaria models to inform policy, in particular looking at bed nets and also the vaccine. But then 6 months or so ago, I started a fellowship at Imperial looking at developing new methods to model infectious disease outbreaks. Unfortunately, the model that I was working on wasn't suitable for COVID-19, but I was really interested in getting involved with this as the work started to begin in the department. And I've been particularly focused on developing a new method for modelling transmission and looking at applying that to Europe and the US.
Okay, that's really useful. Well, great. Well, hold that thought and we'll hear more from you as we go along, Juliet. But another engineer, isn't that lovely? I have an engineering background as well, so I've just learned that about Juliet. So we're kindred spirits. Now let's also say hello to Dr. Katie Gaythorpe, and you're a modelling person as well. We know that much, Katie. Well, we do now. Tell us a bit more about yourself.
Thank you. Yeah, so my background's in mathematics. So my PhD was looking at the effect of interventions on cholera, particularly if there's a natural disaster such as flooding. It was quite theoretical, it was very mathsy, and since then I've got progressively more and more applied, but still focusing on looking at the impact of interventions on disease outbreaks. So I've been looking at norovirus, a bit on Ebola, previously working a lot on yellow fever and the impact of vaccination, and now I'm the research lead of the Vaccine Impact Modelling Consortium. And we look at 10 different diseases, and there's a variety of modelling groups modelling things in a whole variety of different ways, and there's always new and exciting ways to model things, but focusing mainly on vaccine impact and looking at, okay, we can model a situation where there isn't a vaccine or there is, so what's that actual difference in terms of disease burden? And part of the, as part of the COVID response, I've been involved in coordinating the groups. The group's grown and grown. There's a lot of different people doing a variety of exciting research on this, and one of the main things I've been involved with is trying to understand and collate the data streams that we've got coming in, because there's so many different data that we're trying to use and understand.
That is really useful, and just a really brief answer, if you will, because I'm dying to get on to Lilith, who's our third speaker today. But just to help me and indeed our audience here, that we heard about the transmission modelling from Juliet, whereas you're modelling more about actually what goes on if some new candidate treatment comes along. You're more on that side. So she's looking at transmission. You're looking at candidates, treatments, interventions.
So that they're fairly linked. So we want to really get a good handle on what transmission looks like, and then you can start adding this layer and say, okay, well, we've got an intervention, we think it might work like this. How much effect is that going to have on disease spread? Okay,
so they go very much hand in hand. That's good to know. Okay, now also our third panelist, speaker, star scientist, however you want to describe them, is Dr. Lilith Whittle. So lovely to meet you, Lilith. So tell us a bit about yourself.
Good to meet you as well. Hi. So yeah, similar to Katie, I also have a background in mathematics. That was my undergrad. I then took a brief 5-year sojourn working in finance before coming back to do a PhD in the Department of Infectious Disease Epidemiology at Imperial, where I still am based. And yeah, so the diseases I've been focusing on for the last 5 years have been really varied, and so mainly bacterial pathogens from kind of 17th century bubonic plague outbreaks in rural Derbyshire, all the way through to antibiotic resistant gonorrhea. So quite a wide spectrum. Yeah, so I got recruited onto the COVID modelling team around a little later than Katie and Juliet, so probably around March, April time, and I've been focusing on real-time modelling of the UK outbreak, so comparing the different regions, how the outbreak's been progressing, and feeding back to kind of various government panels to make sure that all of our best estimates are being used in response planning.
That is great to know. And just before we hop over to our audience and take some of their questions, this is all as much, I think, about the research community hearing back from the audience as it is about the audience hearing from all of you. So as people sit there now and they're framing their questions, Lilith, is there anything specific that you would find it useful to hear from the audience about their concerns, their interests in this kind of work?
Specific questions to the audience, I would maybe be around communication, and because there's been a lot of technical language that people have had to get used to very, very quickly with this outbreak, and it's gone from talking to friends and family where nobody has really a clue what I did beforehand to now discussing the R number over dinner, which is not something I ever expected. Yeah, so how is everybody finding kind of keeping up with that side of things? Because it seems like everybody now has quite a strong grounding in epidemiology that wasn't there a few months ago.
Yeah, well, I can second that. I must admit that, back to February, I think two things have surprised me. One, that I speak nearly every day about the R number as if I'm some kind of expert. And the second surprise is that I'm cutting my own hair, which I never thought my year was going to pan out quite like that. So lots of surprises going on. Thank you very much. That's really useful, by the way, Lilith. Just before we go over to the audience, Katie, then, you've got to set the audience a bit of homework. So what are you hoping to hear back from them? You know, how can they help you to help us understand what's going on here?
I guess I've got to ask a vaccination question. So there's kind of two sides to this. So firstly, about flu vaccination weirdly, would this make people more interested in getting a seasonal flu vaccine? And I guess one of my other questions that's really interesting is if a vaccine for SARS-CoV-2 suddenly became available, do you think it would change how you behave, how you go about your day-to-day life?
Okay,
Once
that's
you're vaccinated.
marvellous. Thank you, Katie. I think those are really interesting points. And Juliet, you started the discussion this afternoon then. So what are you looking forward to hopefully hearing back from our audience today?
So one thing that's really important, including in our models, is the kind of behavioural response to various things. It's usually we use kind of how people have behaved in the past, but with the coronavirus outbreak, there was lots of new things that were happening that we didn't really know how to include them in our models. And one thing we found for the US was that when a state knew that they were about to impose a lockdown, people began to move about more, maybe taking more visits to the supermarket to stock up. So my question is about how would people prepare differently if they knew that they were going to have to be locked down again? That would be really interesting and help us kind of be able to capture some of this behaviour in our models.
Ah, that's really good. Yeah, so you're very obviously interested in behaviour. So just trying to get a sense of, you know, what motivates people, what people's anxieties are, you know, what their responses are. And that's not just because you're interested in human beings, obviously you are, but actually that really is a big part of the modelling that you're doing, looking at transmission, given that people transmit the disease. So that might stand to reason. So quick reminder for you out there in the audience that we're running until 5:45 British summer time. So we've got about another 20 minutes, just under, and we really want to get your questions. So if you haven't already, put them in the chat. We've got a team of moderators who will pass them on to me and the panel, and you can have the joy of hearing your question being posed to these three fantastic researchers. So just to get to keep the conversation going then, Judith, I wonder if you can start by answering one of my questions, which is just how challenging it is to model this kind of transmission. It sounds ridiculously complicated. How do you even start?
So that's something that we were really faced with in February time when I started working on this. There are some usual types of models that have been used. There's a type of model called an individual-based model, where you look at modelling individual members of the population and how they interact and how interventions apply to individuals. Then there's a type of model that Lilith works on, which is a compartmental model, where you group people into different compartments. So there's those people who haven't been infected yet, those people who are infected, and those people who've been recovered, and look at the interactions between people in those groups. And then there's also the type of model that I've been looking at, which is kind of more statistical. And we're using some maths called Bayesian statistics. So just a fancy name of kind of some statistics that you may have covered in school. And we look at how we can use relationships between death, people who die, and the number of people who've been affected, and the duration that it takes from people getting infected to ending up to go into hospital, and then if they die, that length of time. And it's just including all these things. And it's really difficult at the start because there was really not very much information there about the coronavirus. We were pulling on information from China, then from Italy. So I guess for me, the most difficult thing was the lack of knowledge and lack of data, more importantly, that we had at the start.
Yeah, and it doesn't get much more real time than this, you know, that we are in the midst of the pandemic, coming through it in some places, we hope, for now, but nonetheless, you're gathering data as you're going along, very much hitting a moving target here. Now let's go to an audience question, and Katie, I'm going to put this one to you, so stand by. I think this is great, from Caroline, who says, I heard that I should be keeping my cats inside during lockdown. Can cats get COVID? Is there a cat COVID vaccine? Can you help Caroline out then, Katie?
This is a really interesting question, and I think I've certainly seen a couple of discussions about this, and I can imagine a few people are thinking about it. As far as I know, there isn't a cat COVID vaccine, and the incidence of cats getting COVID, it's very minimal. So I wouldn't be immediately concerned about it. I'm no
Okay.
cat expert, I have to admit.
Fair enough. No, fully get that, Katie. We didn't fully brief you to come in and talk about the veterinary side of things. Just on the off chance, I'm just coming to you, Lilith, because you seem to be such a polymath in this area. If you can look at 17th century bubonic plague, maybe you know something about 21st century cats, but don't worry if not. Either way, it's a great question from Caroline.
I don't have any specific cat expertise.
Okay. Fair enough. No, don't worry.
They haven't recorded a transmission between cats yet, or cat to human, has there been? But then you could always be the test case, so there's always that.
Okay, there might be that. Okay, just before we leave the subject of cats, you never know, we might come back to them. But Juliet, it seems only fair to inflict this one on you as well. I don't know. I'm just throwing it out there. If that would be part of a transmission model scenario, when you're thinking about human to human contact through those phases that you mentioned in your first answer. This doesn't need to be a cat related answer, but this might be an opportunity for you to talk about other things that you take into account in this kind of modelling.
So for some diseases, animal transition is really important. So for things like maybe Ebola, where there's lots of transmission, maybe from animals, bats, or bushmeat, it's really important to consider that in the model. And we would call kind of the modelling that then I've looked at, you kind of have importations. So you have infections coming into the system, and also person to person transmission, which is more what we're looking at for COVID. Okay,
that's great. And there are plenty of questions coming in. And I didn't mean to panic the audience earlier on when I said we've only got 15 minutes. Of course, even now we still have, it's 1:30 here in the UK, because I know that we might have people joining us from overseas. Relax, we've got another 25 minutes. So plenty of time to get your questions in. So I think we've done cats pretty nicely there, but there is another one from Anne on a different subject. And I'm going to put this to you, Lilith, because you started by talking about science communication and explaining things. Now this comes from Anne, anonymous. See what I did there? So we're going to have quite a few Anns today. And but anyway, what Lilith, Lilith, what anonymous is asking, which is what concepts from this whole pandemic have you found hardest to explain to lay people?
I think actually I've had the opposite experience, and I've been incredibly surprised at how receptive everyone's been and how knowledgeable they all are. And I suppose that's a function of it's what's on everybody's mind, and you can't really escape it at the moment. So yeah, everybody's really been incredibly engaged and interested about the whole pandemic, really. The hardest thing to explain, I'm not sure, have you had any more challenges, Katie, or?
Yeah, Katie, so over to you. And Katie, in your answer, if you want to talk about hard things to explain, I wonder if we can widen this out to this awful problem, I suppose, of false information and some of the absolute nonsense that's going around. Apparently there was a story going around that some kind of caterpillar in the Netherlands spreads coronavirus. And of course, I mean, we can all laugh, and I do as well. I laugh at how crazy these stories are, but of course they can be very damaging, can't they, if people act on them and ridiculous decisions are made. So yeah, a science communication question to you, Katie.
I hadn't heard the one about the caterpillar. That's really interesting. Yeah. I guess one of the things that is tricky to explain is, well, not really explaining, but there's such a volume of information. I suppose you said some of it's maybe not completely accurate, but there's a volume of information, volume of sources, and I will get questions that, oh, I read this and it says, some fact, and I won't have seen exactly the same article, so I'll have to go back and track down kind of what the thinking was behind it before I feel I can kind of chip in an answer to the question. So that's been a bit tricky. I'd like to echo what Lilith said. It's been great talking to people about what I've been researching for years. Is suddenly kind of the hot topic that everyone wants to discuss, and sometimes at the end of the day you just want to stop talking about it, and sometimes it's just excellent to talk to people and get their viewpoints on it. Yeah, it's a good point about spurious information. There is quite a lot of information out there, and keeping track of what's going on and what the latest findings are is tricky enough as it is without other information coming in. And as has been mentioned before, this is a human, we have human to human transmission, so people's behaviour is is really important. So we're just hoping with this we can answer some questions and provide some answers from what we're doing, but also there's plenty of good information out there as well.
Yeah, it's good, and I'm really glad you said that, Katie, as well, because obviously I don't mean to be alarmist by bringing in those false information and fake news. I actually don't happen to like the term fake news, but obviously some quite damaging stuff going around. So I'm glad that you also said, but yeah, there's some great information out there. And look, let's hope we don't want to be too self-aggrandizing here on this stream, but hopefully we're part of the solution, as it were, to some of the misinformation problems. Now, Katie, whilst I've got you on, just because I know you, as you said at the beginning, you've studied all kinds of diseases. And Lois asked, a pandemic of this kind has been predicted for years. Is this it? Is this the big one they've been predicting, or can we expect more viruses to appear? So, with your long experience of looking at all kinds of diseases, how does this one stack up?
Oh, that's a really good one. So yeah, I think there's been discussion about pandemics, and a lot of talk about respiratory viruses maybe being the next pandemic. Certainly, we've talked about flu. I'd maybe go back to talking about plague and pass to Lilith, but yeah, I think we can never rule out that new viruses are going to appear or mutate. I don't think, these are relatively rare occurrences, but there are, other disease spread and other virus mutations do occur.
Yeah, okay, that's great. That's really useful. And only if you want to pick this up, Lilith, Katie suggested that you might have something to add, because I know you've looked at historical diseases as well.
Yeah, so I mean, plagues have been occurring, plagues as what they used to be called, as pandemics used to be called, have been occurring throughout human history, from kind of ones that hastened the decline of the Roman Empire all the way up to pandemic flu in 2009 and the 1918 flu, which is the one that probably the most closely comparable to COVID. Yeah, I think there's also an ecological aspect to this, because I think as our world population grows and we come into contact more and more with different animals and different species in their habitats, the likelihood of pandemics occurring or diseases making the jump from species to species, as the contacts increase between species, the likelihood of that jump occurs. So that's the kind of negative aspect of it. However, I mean, if there can be a positive aspect of our response to this current pandemic, this is probably the first pandemic in human history that we've managed a global coordinated response to, which is in human history. So that's like fascinating and amazing to me, that to live in such a time when we can actually come together globally and all address what in the past would have been an existential threat that wouldn't have been wouldn't have been able to be prevented by us in any way. So
yeah, so absolutely. So a global threat with global solutions, and one that will go down in the history books in that way when the Lilith Whittles of the future study the history, I'm sure, of this one. Now let's bring Juliet back into the conversation here, because I think this is a good one, well, for all of you, frankly. But Juliet, let's get you to take this one from Alex. It's been upvoted 5 times, so make it 6, because I'm voting for this as well. Alex says, I would like to ask how accurate the early modelling predictions for spread turned out as time went on, and was this different than the expected margin for error that you might expect from a novel virus like this? Asks Alex. To you, Juliet.
That's a really good question, and something that we have actually looked at for the model that I've been working on, which is this more statistical framed model. One way we can check how accurate our model is to compare something called the attack rate or cumulative attack rate, and it's an idea of how many people have been infected over time. Now we're a little bit further through the pandemic. People in different areas are getting tested for antibodies to see if they've been infected at any point. And we can use these surveys, which have been collected by other people and kind of random samples of the population, to compare our estimated attack rates with the attack rates that they found in their studies. And we found that we've been actually very, very good at predicting these attack rates from the seroprevalence. In particular, there was a survey for New York, and I'm sorry, most people probably here are in England, but like I said earlier, my research has been mostly focused not on the UK. We found that we got very, very close seroprevalence matches in New York for the survey that we looked at. So that was really great.
Okay, that's great. Now, there's the inevitable second wave questions coming up quite a lot. So in fact, I'm going to ask all of you this in turn, because I think just about most of the audience wants to know about this. Like Jan, for instance, says, which month do you estimate the next wave will strike? And then we're back to, let's have a look at this one. Yeah. And again, anonymous, we're seeing a decline in active cases. Does that mean COVID-19 will reach the peak, or are we expecting a second wave? And in fact, as a health correspondent friend of mine at the BBC reminds me that we have to be careful about talking about second peaks versus second wave, and they are apparently different things. The second wave is more like the thing that might be, you know, in the some kind of mutation or development in the virus, maybe as the winter comes on. But you're the expert, so I won't try and unpick those for you. But as you can tell from the audience, all of you, and Juliet, seeing as you were speaking there, I'm going to come to you first with the second peak stroke second wave question. But Katie and Lilith, stand by, because this one's coming to you too. You first, Juliet.
So I'm going to give a little bit of perspective, not for the UK, sorry, again, but in the US, unfortunately, we're beginning to see cases rising. We're not sure how sustained these will be, and if different interventions get put in place and people change their behaviour. Although we can see these cases increasing, it may not result in the deaths increasing, especially if well, with the new drug that's this research has found to be effective. If you manage to give those to the people that need it, this might help stop the second peak. Okay,
and that's great. So you gave no worries at all talking about New York, because that leaves it wide open then to come back to first you, Katie, and then you, Lilith, maybe to talk, if you can, about the UK, or indeed other parts of the world that you know more about. So, you know, take it in whichever direction you want. But let's come to you first on this one, Katie.
So I guess I'm going to respond more generally. In terms of modelling, we had the conditions for cases to be growing before, and so if we return to those same conditions, and I'm talking about kind of certain interventions being lifted and behaviour going back to what it was, we would probably see growth in cases again. This is partly because we're not quite at herd immunity, which I think has been mentioned before. So we're not quite at that herd immunity threshold that the transmission is going to be self-limiting. But we've been talking a lot about the new normal, and we've got a lot of interventions in place, and people have changed their behaviour. And as we keep saying, the human behaviour aspect is so vital. And so if we manage to control things, and I'm going to mention the R number, and I suspect this will come up a lot, but really thinking about keeping that R number down, and meaning that the transmission is not going to start propagating or spreading again, then we can kind of mitigate the chances of a second wave. But it is a real possibility.
Okay, thank you very much indeed for that. And in fact, we've had similar questions coming in from YouTube. So Lilith, another YouTuber here, or responder on YouTube, says, are you modelling a second peak in the UK, and when do you think this might be? So over to you.
Well, so the thing about the second peak is, as well, and when we talk about waves or peaks, it kind of sounds like that's an immutable, natural thing that's inevitable. Whereas, as to echo what Katie was saying, this is something that's influenced by behaviour and by the conditions of transmission. So the thing to note about the UK is the serological surveys that Juliet mentioned previously, and these are surveys where you have a blood sample taken, and then the blood's tested for the presence of COVID antibodies, which will test whether you've ever been infected with COVID, not necessarily are currently infected with COVID. So by doing these serological surveys, we can get an idea of the number of people who have ever been infected, and that's how we would get at the idea of how much immunity is there in the population, although the two aren't exactly linked, and how that might affect transmission going forwards. So in the UK, we know that in London, which is the area of the UK that has seen the most cases, most severe epidemic, we're probably only around 17% seropositivity, or 17% of people have ever had COVID in London, according to a PHE survey from recent weeks. So the conditions are there for a second wave or second peak to occur if behaviour changes to the extent that the virus can start spreading again. So there's nothing from that perspective. There's not really anything that's preventing the second wave apart from us, really.
Okay.
Positively, though, we've shown that lockdown measures have worked to mitigate that, so that's something we can always explore again.
Yeah, and even as we come out of lockdown, we hope that the social distancing measures that are put in, the increased hygiene, hand washing advice, all these things should at least do their bit to hopefully prevent, but at least reduce a really serious second peak, we hope.
Yeah.
And I suppose, knowing that the country went into lockdown almost at the click of the fingers, you know, if the worst happened, I suspect we would do it again and would have to. So, but I'm rather dangerously veering into speculation there. But one thing I have picked up from you there, Lilith, is that we're still a long way in that London case that you gave, those figures you gave from London, a long way from herd immunity. Okay, that's really, really useful. So Sesha, I'm going to come back to you on this one. It's about modelling and other diseases and using your engineering background and experience of other diseases. Really great question here. Are there any reliable models to predict the impact of COVID-19 on other infectious diseases such as TB and HIV, or pick your other disease that you might know more about? So what do you say to Sesha?
So I know that this work is going on in the department, but it's not something that I specifically have been focused on. I used to work on malaria, and there's been a team in the department who've been looking at malaria, and they found that because malaria impacts lots of people, mainly in sub-Saharan Africa, the kind of interventions and things that they can put in place really differ, and the level of hospitalisation and the number of beds. So it's really important to consider what impact things like lockdown would have. For example, if a country in Africa went into a full lockdown, this may stop bed nets being delivered to those people who need them, and this. Well, with malaria, bed nets have been shown to be a really important intervention into stopping people getting malaria, because they they're a barrier to prevent people being bitten by the mosquitoes. So stopping these nets getting out to the people that they need, this could be potentially as damaging as COVID itself. So it's really important to consider these different diseases when modelling COVID. And there's a team looking at this in the department, and a few reports and things out there if you want to go and have another look.
That's really, really useful. Okay, and I've got a data question here for Katie. We don't have the name of this questioner, so I think it's another anonymous. But Katie, is the lack of data the limiting factor, or is it the matching techniques that would apply to COVID as a new virus? So really, I just summarising the question as I understand it, is like how limiting is a lack of data?
This is a really great point, because it definitely comes up not just for COVID, but I mean practically everything I've ever worked on disease-wise. But there's always been questions about, oh, it'd be really great if we knew this. So one of the things about COVID is it is a new virus, so we are learning things all the time. It's not been around that long, so we don't know what things look like 6 months afterwards, 2 years afterwards. We're not sure what that looks like. What we can do is borrow information and insight from other viruses, other coronaviruses, to get an idea about what we think it might look like. We also, and Etty's already mentioned this with the Bayesian statistics, that's one of the ways that we can quantify uncertainty in our models. And that sounds really hand-wavy, but I find it very exciting, but maybe that's because I'm into the mathsy stuff. But when we start to quantify uncertainty, that can give us information about what can we say with confidence and what can we say we maybe need more information. So that can feed back to people gathering data, but it can feed back into how we build our models. So you don't want to start adding extra complication if you can't back it up with data.
Yeah, of course. And I guess so much of what you do on the statistical side is obviously going for certainty. and probably wanting to quantify how certain or uncertain you are, being certain about the uncertainties, as it were. Is that the case?
Yeah, there's certainly uncertainty about it.
Yeah, absolutely. Okay, now we've also had this from Sabine. Lilith, I'll put you on the spot with this one. This is from the YouTube video, the YouTube viewers, I should say. So hello to you lot watching the stream on YouTube. And YouTube wants to know, Lilith, about getting it twice. Can you get COVID-19 twice? Do we know?
Well, that's the million-dollar question, really. So there have been reports from China of individuals who have tested positive twice for COVID on two separate occasions. It's interesting, though, because the test that's done to check if someone's currently infected with COVID is an antigen test, and it picks up the DNA of the virus. But sometimes there's a chance that test could produce a false positive. There's also the chance that the false positive could be due to the test picking up dead copies of the virus rather than live copies. So a positive test followed by a negative test followed by a positive test doesn't necessarily have to mean reinfection. There's also a question around perhaps whether those cases were perhaps due to an individual having being immunocompromised as well. So, I mean, just to summarize, there are so many questions that we still currently have to research, particularly around immunity to COVID, and this is something that we really need time to find out the answers to. How long does immunity last? We'll have to wait that out and keep testing in order to find the answer to that question. So, yeah.
And it's such a big question, isn't it? And maybe a lot of it has to do with viral load, possibly. If you had it really heavy the first time, maybe you're less likely to get it a second time. I've read that. I don't know if there's any truth in it.
Oh, I should actually add, though, that the best estimate so far is that the COVID infection it's looking like it does provide at least some measure of immunity for kind of at least 6 months after infection. So that's our best kind of research at the moment is suggesting that.
Yeah, okay. So we're just getting into the final phases here, folks. Still time to sneak the odd question or two in, according to my watch. We have about another 7 minutes to go, but I'm going to come back to Juliet for this one, and it's another anonymous one. The question is, do you think, knowing what we know now, are there more or maybe fewer measures that should have been implemented in this crisis?
That's a really good and interesting question. It's difficult to go back and think and hypothesize what would have happened when governments or people were trying to put in interventions. They didn't know what impact they would have, so they didn't know if the government said you should not go out, they didn't know how strongly people would adhere to that. So it's very difficult to put these.
No, fair enough. And so, okay, well, I've just thought of another way of asking you that question, or something I'm just really interested in, given that you do have this link to policy, these real-time predictions to policymakers. And I wonder what that looks like in practice. If you've got like maybe at home like a red telephone that's directly linked to the Cobra committee, and as soon as something flashes up on your screen, you wire it through to them. What does real-time look like in practice?
Well, maybe Neil and some of the other people have that red telephone, but for me, it's been very much a team effort. So one of the senior management team will have a question, and then they'll go down and find the best people in the team who are most equipped to answer that question. One thing that I've been doing with my modelling has been helping to advise the New York State government. With my boss, he's been advising them, and I've been helping provide him with the information about that, and that involves telephone calls. Just talking to people, explaining our results, explaining the assumptions that our results are based on. I think that's really important. We're trying to produce the most accurate results we can, but it's still based on lots of things that we don't know.
Wow, it's amazing though. I mean, it's disease modelling at the sharp end. It really is. You know, it's a very dramatic story. I think probably time for the last question. And I've got a few wrapping up questions just as we begin to call it a day and then head off heroically, we hope, into the sunset. Let's come back to you, Katie, for this one, which is about people shielding. And this is, again, another anonymous one, which is, how do you model the behaviours of people who are shielding? Because it must be hard to get that kind of data.
So yes, I mean, it is going to come back to that behaviour aspect, the human to human context. So we do have a group working within our team who's looking specifically at this. And it comes back to talking to people as well. The only way you figure out how people's patterns are changing over time is by talking to them. So we have surveys where people are asked various questions about how their behaviours changed, and part of that is going to be shielding.
Okay, that's really useful. I think that is the main thing I wanted to find out from you. It is about behaviour, isn't it? This is understanding behaviour. So we're, on one level, we're going right into the proteins and the DNA and the really complicated and antigen stuff related to the virus, but we are looking a lot at human behaviour here. Right, so I think about 3 minutes to go. So I think I'm going to go round in turn and just get each of you to round off. So whilst your mic is open, as we say at the BBC, Katie, let's finish with you. And I want to look to the future as we round this discussion off. And RJ, one of our questioners, is helping us do that, saying, does epidemiology, or your field in mathematical modelling, Katie, have a new place in politics and society, looking beyond this current emergency? And if yes, what do you think that will look like? What kind of opportunity, we hope, does this pose to you and your peers?
So as someone who's already been interested in this before, I would say yes, it's got a place in politics and society. I think it's great that people are talking about it. We're having really frank discussions, and people are learning new things and discussing them. And as we keep mentioning, that human behaviour aspect is so important. So I really hope it's got a new place in politics and society. But I mean, I keep coming back to vaccination. That's been part of our health system for some time. So I would say it's already there in some respects.
Right. OK. So Lilith, what about you? You've got about half a minute. Politics, the future, your future research. What's on the horizon for you?
All of that in half a minute. Okay, so I've been really happy to see modelling kind of discussed more openly, in particular because for me mathematical modelling is just a structured way of thinking about a problem. We all kind of build models in our head all the time. We just don't necessarily write down what assumptions we're making and the process by which we've done it. So mathematical modelling is just kind of a structured way of doing that by taking account of all of the best evidence that we have, combining it in a way that can be reproduced, and seeing, kind of have a look at what we do know and how much we don't know, as you mentioned earlier, Gareth, based on all of these different data sources. So I'm very glad to be able to talk to people about that, and that it's being taken into account in policy.
Marvellous. Thank you so much, Lilith. So finally to you, Juliet, and more or less a yes or no answer, I'm afraid this will have to be, but the rehabilitation of the expert and a bright future for your field as this obviously very unfortunate situation goes forward. Oh, you're on mute.
What I've been focusing on my fellowship on is researching new methods for outbreaks, and I think it's really important that we look to other fields, we look to different ways other people are modelling different things, and try and include those in our models. And that's something that I think, having a background in engineering, I think it's really important to be encouraging people whose backgrounds aren't necessarily in diseases, but to come in, bring their expertise, help us to develop the field.
Okay, look, and there we're going to leave it. So right on the nose there. We've just got another minute just to say thank you very much indeed. If this was a live event in front of an audience, you would be getting a standing ovation right now. So thanks to all three of you, Juliet Unwin, Katie Gaythorpe and Lilith Whittles. You've been absolutely brilliant and just answered those questions wonderfully. So just before I go, just to say we do have a feedback survey, and this is the first one of these we did. So we really need your feedback, folks. What did we do well? What could we do better next time? Because we're figuring this stuff out as well. So there is a link, I think it's coming up on the screen in front of you. You can check it in the chat and the comments, but please give us some feedback, because we just want to nail this format and really get it working as well as we can. Our next talk about COVID-19 Q&A will be in the week of 13th of July, date to be arranged, but we'll let you know. And the subject is going to be health inequalities. So that is it. Suffice to say, thanks to our panelists, and also thank you to the moderators, the organisers. I won't name everybody because I'll miss people out, but they knew who they are and they've worked really hard. And this has been an ambitious event, believe you me. So well done them, and I hope they can go and grab a drink after this. I'm your friendly host, Gareth Mitchell, signing off for now, thanking you so much, all of you, most importantly, for being here. And of course, we've been saying it for the last few weeks now, stay safe, won't you? And join us for the next one. Goodbye from us all.